One, minutes,
Yeah.
people on the.
Are we ready?
Yeah.
Oh, okay.
What do we want?
Good morning, and thank you for joining us for Winship Grounds this morning. If you're an Emory University or healthcare employee and you would like to receive a CME credit hour for attending today, the access code is 745925, and that can also be found in the chat feature at the bottom of your screen for our virtual attendees. If you have any issues with this webinar or the CME login, please send Kadiatu Fofana an email or drop a note via the chat feature. This morning, we are really pleased to welcome Dr. Ram Subramanian. Dr. Subramanian completed his medical degree in 1998, followed by residency at the University of Chicago. He then completed his fellowship in hepatology in 2002 at the University of Nebraska. This was in addition to his fellowship in pulmonary critical care medicine in 2006 at the University of Chicago Medicine. Dr. Subramanian is a professor of medicine and surgery here at the Emory University School of Medicine in Atlanta. He is the medical director of the liver transplantation and also the director of liver critical care services here at Emory. His fellowship training involved combined training in pulmonary and critical care medicine and gastroenterology and transplant hepatology. This has allowed him to focus his clinical research interest in the field of hepatic critical care and inpatient hepatology. Throughout his academic career as a hepatologist and intensivist, he has developed specific clinical research expertise in extracorporeal liver support and hepatic critical care. In addition, he has completed an MBA at the Emory Gozueta Business School and a master's in healthcare delivery science at the Dartmouth Tuck School of Business to apply this knowledge to healthcare delivery and administration. Please join me in welcoming Dr. Ram Subramanian today for his talk, Advances in Extracorporeal Liver Support. Thank you.
Dr. Alicia, thank you for that kind of introduction. It's a pleasure to be here, and thank you for inviting me. So we'll talk about advances in extracorporeal liver support. And as I was thinking about this topic, as you know, I spent a lot of my time in the ICU and with sick liver disease, and I was trying to make sure I make this pertinent to this audience in the context of oncology. So hopefully you'll find some of this content interesting and to think about how hepatic failure can overlap with oncology, which I think you see a fair amount of the time. So with that brief sort of introduction, let me get started. I have no disclosures with respect to this talk. So from an outline standpoint, number one, I want to start with reviewing the etiologies of liver dysfunction and failure sort of in an oncologic context. So we'll start with that. And then I want to move on to discussing the goals of extracorporeal liver support. And I'll use the acronym ECLS for the rest of the talk in the different forms of liver failure. And broadly speaking, we'll talk about sort of two phenotypes of liver failure. One is acute liver failure, which is acute hepatic dysfunction in the absence of chronic liver disease, so the classic Tylenol overdose or Hep B reactivation, if you will. And the other phenotype is acute on chronic liver failure, so that's decompensation of prior cirrhosis. So we'll make that distinction as we talk about how we think about applying ECLS systems to these forms of liver failure. And then I'll get into some of the granular details of different modalities. I just wanted as a sidebar note, Emory has been leading the way in North America as far as some of these therapies, and in particular albumin dialysis. So I'll share some thoughts with you on that. And then we'll finally finish up with thinking about where I think this field is progressing for the future. So that's the outline for the next 45 minutes. So let's start with etiology of liver dysfunction in in the context of cancer. So I think you're all familiar with this, but just to review this, so the first sort of broad topic is toxic effects directly from the tumor itself on the liver parenchyma. So hepatic metastases, so classic lymphoma spread that can cause liver failure. Vascular thromboses, either from the portal vein thromboses or on the other side from the hepatic vein thromboses, that can cause complications, including ischemic, sort of hepatic ischemia. The rare syndromes of paraneoplastic syndromes, for example, in renal cell carcinoma with sort of severe cholestasis. So that would be another example. Infiltration with sort of amyloid is another thing we've seen rarely, luckily, but that can happen as well. So that's sort of the broad category of toxic effects from the tumor itself on the hepatic parenchyma and the vasculature. The other broad category we need to think about is when you are considering treatment from an oncologic standpoint, is there pre-existing chronic liver disease that can then set the stage for hepatic decompensation? So classically, somebody with chronic liver disease, such as NASH, as you know, there's an epidemic of NASH, and hepatitis C, which luckily, as you know, is going away with the new drugs. The other broad category that, and I'd do some digging, I'm slightly out of touch with all the latest in chemotherapy, but this is interesting review for me to sort of see even the newer agents, all the potential hepatic side effects of your chemotherapeutic regimens, even the targeted chemotherapeutic regimens that can have with respect to hepatitis, cholestasis. So that's a broad category, and we'll sort of touch on those as we move forward as well. Concomitant hepatotoxic medications, classically some of the analgesics, and I'll share with you a case or a sort of Tylenol overdose, but that is something you got to watch out for. The other epidemic in a hepatic context that we are seeing, which may be pertinent to your patient population, is the uncontrolled use of herbal medications. So anxiolytics, analgesics that are not FDA approved, but are used rampantly in the US and I would say in particular without any FDA approval. And so that is causing an epidemic of acute liver failure, and we become a referral center for some of these unfortunate sort of side effects. So I'll share with you actually a case that from many years ago, there was an example of an herbal hepatotoxicity, but that may be pertinent to your patient population as well. Coexisting medical conditions. So if you have, for example, cardiac dysfunction from a chemotherapeutic agent, how that can affect hepatic function. We have systolic or diastolic heart dysfunction, how that can then translate to, for example, a worsening hepatic function. So that'll be an example there. And then finally, sort of infections. Yeah. So just to sort of give an example of that, acute hepatitis B reactivation, which can really become a problem with respect to acute hepatic failure. So that'll be an example of infection. Then you have all the other infections that can happen in immunocompromised hosts that can have hepatic manifestations. And then finally, I want to share this with you. And at some frequency, I've been in touch with, we get the calls from surgical oncologists where they have post-hepatic resections liver dysfunction or liver failure rarely. So when you're doing partial resections of the liver, at some frequency, you can have residual or post-surgery hepatic dysfunction that can lead to acute liver failure or acute hepatic dysfunction. So just a few examples of sort of setting the stage for all the different forms of hepatic dysfunction that can happen in sort of your context in the oncologic field. All right, so with that background, let me just sort of get into some of the more sort of hepatic specific issues. So let's talk about classification of liver failure, and this may be old news to you, but just to recap on this, broadly speaking, I think it's important to make this distinction between acute liver failure or acute liver injury, and this is an acute and chronic liver failure. So let's talk about ALF. So ALF, by definition, is acute hepatic dysfunction in the absence of chronic liver disease, so no underlying portal hypertension. And classic examples, I put an example of a chemotherapy agent like sorafenib, but the classic sort of a textbook description is Tylenol overdose. And then the other thing that's pertinent to our immunocompromised host is the reactivation of hepatitis B. And this physiology is such that there is a finite chance of reversibility back to normal hepatic function because the liver can regenerate if you give enough time for the liver to regenerate with aggressive supportive care. So that is a sort of a unique form of liver failure that we see at some frequency. So as you think about ECLS systems, extracorporeal liver support systems, the way we've been thinking about this is here in this context, you can use it as a bridge to either A, intrinsic hepatic recovery if the damage is not too far gone. We've done that at some frequency, or if the damage is done, then how do you use that device to bridge somebody to life-saving liver transplant? So that's the way I think about ECLS systems in the context of acute hepatic failure or acute liver failure. So the other form of liver failure, which is more common, which is now 90% of our cases, is acute on chronic liver failure. And that's sort of a redefinition of decompensated cirrhosis. So here, ACLF is basically decompensation of prior chronic liver disease. So the classic descriptions in the liver context is decompensated NASH cirrhosis, alcoholic cirrhosis, hepatitis C cirrhosis. But in your context, some of the examples would be, for example, VOD from chemotherapeutic agents, or somebody that already has pre-existing liver disease that's now decompensating in the context of receiving some oncological treatment. So here, in contrast to ALF, the resolution of the acute dysfunction, like hepatorenal syndrome, hepatic encephalopathy, does not lead to resolution of the underlying fibrosis or cirrhosis. So here, the goal is to use that extracorporeal liver support system as a bridge to temporary stabilization, get them over the acute event, with a goal to then potentially, again, the hepatic context of bridge them to transplant, or in your context where the oncological process may be a contraindication of transplant, to stabilize them through the acute event. So I just want to make this distinction because this is an important distinction as we think about management. And number two, you think about how you use ECLS systems and define goals of care in these two disease processes. All right, so now let's sort of switch gears and talk about how would any of these devices work. So what's the mechanistic rationale? So let's assume you got stable hepatic function. You have an acute insult. It could be ALF, it could be ACLF. And here the rationale is that you have the accumulation of certain hepatic-specific toxins, and we'll sort of tease this out a bit more. And those toxins can have a couple of negative downstream effects. Number one, it increases the risk of multi-organ system failure. So imagine a classic cirrhotic patient or chronic liver disease patient. They can have hepatic encephalopathy, they can have distributed shock, they can have hepatorenal syndrome. So as these number of organ failures start adding up, that leads to higher risk of mortality, as you know. So this is one negative downstream effect of this toxin accumulation. The second negative downstream effect that in particular applies to acute liver failure is a negative feedback loop on potential hepatic regeneration. So as you think about these two themes, if you were to come along and create an extracorporeal liver support system that can extract those toxins, you can have sort of a dual benefit. Number one, you mitigate multi-organ system failure and thereby improve survival. The second is you can potentially enhance potential intrinsic hepatic regeneration. And this is where I think ECLS systems can be very helpful, and we'll sort of elaborate on this a bit more. And then you couple that with aggressive critical care management, and you can really make a difference with respect to the mortality of these patients in the acute care setting. So that's sort of mechanistic rationale for how any of the ECLS systems would work. All right, now let's get into sort of ECLS categories. And broadly speaking, we define them as artificial liver support, i.e. there's no hepatocytes in the extracorporeal setting. And we'll spend most of the time actually the majority of the time on this talk in here, but the mechanism here is similar to renal dialysis. You detoxify. There's no synthetic ability of that extracorporeal support system compared to what we'll talk about in the second half of the slide. And so here are the examples that we'll go over. Number one is alveolus dialysis. And you may have heard about the MARS system, molecular adsorbent recirculating system. And as a sidebar note, Emory is leading the way in North America with respect to this technology. The second thing that I wanted to sort of just talk with is good old plasma exchange. It's actually resurfaced as an important intervention in the management of acute liver failure, and I'll share a case with you that highlights its efficacy. And then finally, is one of the things that's been a game changer for us in the management of acute liver failure is high-dose CRT. And this is almost 3 times what we do for general septic shock, but that has really made a difference with respect to the management of neurologic dysfunction in acute liver failure by managing hyperammonemia. So I'll share that with you as well. So this is all examples of artificial liver support, and most of these data, the studies have been in this domain. The second category of extracorporeal liver support, which is the holy grail, if you will, is artificial liver support. And here you are incorporating hepatocytes into the extracorporeal circuit. It can be human hepatocytes, it can be porcine hepatocytes have been studied. And here the mechanism is mimicking comprehensive hepatic function, not only mimicking detoxification, but also the synthetic abilities. You can make albumin, you can make coagulation factors. So this is sort of the currently not achieved goal of a lot of sort of research and a lot of it is coming out of Europe, where how do you create an effective bioartificial liver support system? And so far we haven't reached that goal. Some of this, I won't sort of get into the details of this, but there's a couple of failed trials. And the ELAD trial was an example of a human hepatoblastoma cell line, actually the immortalized cell line that was to be used, but unfortunately it was a negative trial. And the other, we've also looked at porcine cell lines, and all these have been negative trials with respect to survival benefit. And a couple of the lessons we've learned from these experiences is that how do you maintain cell viability in that column for a clinically significant period of time? So imagine you're a sick liver patient, and you got them on circuit for about 5 days. Is that sufficient cell volume and cell viability to support that sick patient and get them through the acute event? The second thing we've learned as we have tried to do these in vitro columns is that, interestingly, the ELAD cell line, for example, lost its urea cycle function. It lost its ability to fix ammonia, which, as you know, is an important part of treating these patients. So that's the other sort of limitation that we're learning about is as you try to mimic hepatocyte function outside the body, these are some of the limitations that we're dealing with respect to the technological advances that are required to make this successful. So for the rest of the talk, I'll be focusing only on artificial liver support. All right, so let's start with with albumin dialysis, and this is called the MARS system. And the principle of, just to sort of dive in a bit deeper into the MARS system itself. So, as you know, an albumin in the acute care setting is used as a volume expander, especially when you have shock that's refractory to crystalloid therapy. So that's sort of the critical care angle. But in addition to that role, there's an important role of albumin in binding toxins in the blood, and protein-bound toxins in particular. And in liver failure, they become even more important, but because you have dysfunctional albumin, and that has been studied in cirrhotic patients. So you not only have a quantitative defect, the albumin is sitting at like 2, but even that residual albumin has been documented to be defective with respect to binding properties. So there's qualitative defects as well. So given these limitations, it makes it interesting or mechanistically attractive to use extrinsic albumin to compensate for the dysfunctional intrinsic albumin. And so here's the albumin, the MARS membrane. And so as you think about this, I would draw a contrast to CRT, what we use for renal dialysis. So hopefully you can see this arrow. So this is the MARS membrane here, and here's the patient's plasma, and here's the dialysate. So a couple of differences as you contrast this with CRT. Number one, you've changed the dialysate from an aqueous dialysate that you use in CRT to a 16% albumin solution. So you suddenly create a diffusion gradient between the dialysate and the patient's plasma with respect to extracting albumin-bound toxins. The second thing you do is you increase the pore size of this membrane in such a way that in addition to these circular low molecular weight substances that come off with CRT, potassium, BUN, phosphorus, you can now extract these, what is denoted as triangular toxins that are slightly larger middle molecular weight substances that are albumin bound that can now come off with this circuit because you've changed the dialysate to albumin and you've increased the pore size compared to CRT. So that, in a nutshell, is sort of the principle behind how the Mars membrane differs from CRT and how you can suddenly extract a whole new class of toxins that are specifically albumin bound. So this is sort of, I think, a useful slide that sort of gives this difference. On the right, you see a host of molecules that are water soluble that come off with regular renal dialysis, CRT. So just, I think, so BUN, for example, creatinine. And interestingly, ammonia falls here as well. And this will become important when we talk about management of acute liver failure. On the left is a host of molecules that are albumin bound that will not come off with CRT, but suddenly with the Mars circuit, for the reasons we spoke about, they can start extracting these toxins. So let me just draw your attention to some of these. So endogenous benzodiazepines is one of those molecules that and I'll share with you that one of the main Mars indications that we're using in the hepatic context is reversal of refractory hepatic encephalopathy in cirrhosis. There's RCT level data supported, and that's been our experience as well. And the mechanistic rationale for why Mars works, we think, is maybe the extraction of these endogenous benzodiazepines. The second thing that, and this may be of particular attention to this audience, is, and I'll share with you some published data, is reversal of severe jaundice, severe cholestatic liver injury. So we're talking about bilirubins of 50, 60 that can happen, and typically with drug-induced liver injury. We've actually reversed that effectively with using the Mars circuit, using the properties of extracting bilirubin, which is an example of a albumin-bound toxin. Just on, again, the critical care side, there's data for nitric oxide scavenging. I must admit, I've not seen that effect that being that pronounced, but there is published data from the Europeans on that. And then finally, as a sidebar note, we've actually taken Mars out of the hepatic context and used it in the toxidrome in the critical care toxicology, using the properties of extracting highly protein-bound drugs. So an example would be amlodipine toxicity. We actually had a patient come in with severe shock from amlodipine, sort of an intentional amlodipine overdose. And that patient would be heading to ECMO. But amlodipine is 95% protein bound. So we actually hooked this circuit onto the patient, and within 24 hours, the patient was on rocket fuel. And within 24 hours, the patient's shock resolved. Because we were able to use the properties of the Mars circuit, and remember that it sort of extracts highly protein-bound drugs. And so we've used that strategy. So we sort of communicate with our poison control center at some frequency to use the Mars device. So there's published data on phenytoin toxicity. There's published data on carbamazepine toxicity. So any drug that is greater than 50% albumin bound, and this will become pertinent to this audience as well, and there is a toxidrome associated with it, may be a candidate for thinking about Mars therapy in order to reverse that toxidrome. All right, so what does this look like in a circuit? This is regular CRT. So you got a single membrane, a regular sort of trialysis catheter, and the aqueous green dialysate. This is the Mars circuit. Let me just walk you through this. So this is a regular dialysis catheter, but this is that first membrane is what I had shown up for you blown up in the previous slide, where you have the pore size slightly larger than the CRT machine, and you have an albumin dialysate going countercurrent to the patient's blood. So at this stage, you have the extraction of both water-soluble toxins and albumin-bound toxins, so both the circular and the triangular toxins. And then the albumin effluent then passes through a regular CRT column where you extract the water-soluble toxins like BUN, creatinine, potassium. And then what's left here are the specific albumin-bound toxins like endogenous benzodiazepines, bilirubin, that then get sequentially removed using a charcoal column and an ion exchange column. And then the rationale here is that the albumin that's coming out of here is cleansed. The binding sites are cleansed, and they're ready to see the patient's blood again. So this closed loop of albumin is about 600 mils, and that's why it's called a molecular adsorbent recirculating system. You're recirculating the albumin. And these two cartridges are good for 8 hours, so we got to change that every 8 hours. But this is the sort of the circuit that involves the Mars system. So just sort of a few logistical issues. So this is 8 hours of Mars therapy. You got to switch these cartridges every 8 hours. We typically do a total of 5 sessions. If we see efficacy, we'll see it. The albumin dialysate is a simple mixture of normal saline and 25% albumin. From a blood flow standpoint, just to sort of talk about tolerance, CRT blood flow is typically 200 mils per minute. So the Mars is even lower than the CRT. So practically speaking, if you have a really sick patient in shock, in septic shock, for example, on pressors, if they are tolerating CRT, they'll easily tolerate the Mars circuit because the blood flow is even lower than CRT. And then from an anticoagulation standpoint, we do similar to CRT. We start with no anticoagulation. If we need anticoagulation, we do regional citrate anticoagulation to minimize the risks of heparin systemic anticoagulation in a coagulopathic patient. So that's sort of the Mars circuit, and with respect to sequential cleansing of water-soluble toxins and then albumin-bound toxins. So let's talk about sort of the beneficial effects of Mars, and I must admit, a lot of it is observational trials of studies because it's not used in many centers, so we're trying to put our data together. But as I mentioned to you, and I'll show you some data, improvement of jaundice and pruritus. This is something that, because of the bilirubin extraction. There's some data for nitric oxide scavenging and hemodynamic instability, but I've put a question mark there. And then I want to draw your attention to bullet point number 4, because I think this has become a backbone of our indication, is especially in chronic liver disease, when you have refractory hepatic encephalopathy, there's RCT level data that actually reverses that physiology. So imagine a cirrhotic patient, or underlying chronic liver disease patient who's failing lactulose, rifaximin, zinc therapy, and still has dense hepatic encephalopathy. Predictably, with Mars therapy, they will awaken typically at session 2 of Mars. So that's been our experience as well. The other thing again, this is more the hepatic world, but the other thing that's becoming interesting in the liver transplant world is, can you use Mars as a bridge to transplant? And this is, again, based on European retrospective data. This was published many years ago. But what this says is, if you take a really sick cohort of acute on chronic liver failure patients and look at 14-day survival, really short-term survival. So imagine a patient with hepatorenal syndrome, encephalopathy, shock, and look at Mars versus standard of care. You can really make a dent in the short-term mortality. And the strategy here is, if you can bring them into spec for transplant by really making a difference in short-term mortality, once the new liver goes in, the whole system resets. And these patients have outcomes post-transplant that equal even sort of lesser sick patients. So this has sort of spurred interest in using Mars in cirrhotic patients as a bridge to transplantation. And so we're getting more and more calls about, can we have a really sick patient with acute on chronic liver failure who other centers may deem too sick to transplant? Can you think about using Mars, stabilize them as a bridge to transplantation? So I want to share this with you. This may be in particular be of interest to you, is application of Mars in severe cholestatic drug-induced liver injury. And this, I think, applies to sort of some of the oncologic processes as well. And this is just a sort of a publication in one of the critical care journals, but just to draw your attention to some of the culprits here. We had methimazole, we had some anabolic steroids, and the other thing, as I mentioned to you, is herbal hepatotoxicity. We're seeing severe cholestatic liver injury, and these bilirubins are sitting as high as 50, 55. And so these patients did not have underlying chronic liver disease. So what we did is we gave them Mars therapy for 5 sessions, brought these bilirubins down, and then we followed them over time in the outpatient setting, and this almost jump-started the liver, eliminated the cholestasis, and got them back to recovery. And these patients, as you know, if the jaundice languishes, that can then lead to subacute liver failure and also to chronic fibrosis and cirrhosis. So something to think about if you have refractory or jaundice, to think about, and and typically don't have underlying chronic liver disease, to think about using Mars as a effective strategy to reverse severe cholestasis. Just to briefly talk about RCT, sort of higher level data, there's not much published yet, and a lot of it is older data coming out of Europe. But just to summarize the findings of these few RCTs, when you look at transplant-free survival benefit, this has been there's been a negative sort of a experience, have not yet documented a survival benefit if you look at transplant-free survival. And that's sort of my personal editorial is as you think about the future, I think we need to redefine efficacy as far as bridge to transplant rather than transplant-free survival. So without getting into the details, again, a lot of European studies, there's ACLF trials, there's ALF trials, all of them have been negative with respect to the endpoint of transplant-free survival benefit. There is data, if you look at non-survival endpoints, such as reversal of refractory hepatic encephalopathy, with respect to Mars efficacy. So this is, as I've mentioned, has become one of the backbones of our indication. And from a safety standpoint, and this has been our experience as well, no adverse events or increased adverse events in the Mars group compared to standard of care. And as I'd sort of alluded to, I think as you think about the future, and I think we are poised to think about this more since we use Mars more than other centers, is to think about Mars, defining Mars efficacy as a bridge to transplant. So looking at overall survival as an endpoint rather than transplant-free survival. So based on all of that, how are we using this at Emory? So we used to use a lot of it in acute liver failure, but I'll share with you that we have switched to high-dose CRT as sort of the strategy for management of acute liver failure. So we're not using Mars in acute liver failure. This is something we are thinking about on a case-by-case basis is can you bridge folks with chronic liver disease and acute and chronic liver failure to transplantation? As I'd already mentioned ad nauseum, reversal of hepatic encephalopathy in ACLF. And this becomes important because you can then prevent intubation, facilitate extubation, and avoid all the negative effects of positive pressure ventilation in these patients. I've already shared with you treatment of cholestatic drug-induced liver injury become a referral center for toxidromes and for drug-induced liver injury, especially cholestatic liver injury. This is more of a homeopathic indication with refractory itching. There's actually data for PSC and PBC in liver disease. So that is something that hits your radar as far as refractory pruritus. That may be something to think about. The other thing from a hepatic standpoint is alcoholic liver disease. So you know there's an epidemic around the world in North America. And we are changing our paradigm regarding transplantation. So previously we used to think about 6 months sobriety, enrollment in AA, but now on a case-by-case basis, we are transplanting for acute alcoholic hepatitis. And we can chat more if you're interested about, we're trying to create objective criteria, but we are now using Mars as a bridge to stabilization in acute alcoholic hepatitis as well. And then lastly, I want to mention this actually more recent sort of data. There's actually a patient who had pancreatic cancer with hepatic mets and developed acute kidney injury in the setting of severe jaundice. And interestingly, this patient got transferred from Decatur. He had a kidney biopsy that showed bile calcium nephropathy. It was one of those rare cases we actually had biopsy-proven bile calcium nephropathy as a cause of acute kidney injury. So we actually used the Mars device to reverse that hyperbilirubinemia. So the bilirubins were sitting in the 40 range, and they were causing acute kidney injury. And we treated them with Mars, and we were able to reverse the AKI because we removed the bilirubin plugs in the renal tubules. So I thought it was interesting, sort of a overlap into an oncologic context where we actually use Mars to reverse AKI in the setting of cancer-induced severe hyperbilirubinemia. All right, so that's the Mars sort of story. Let me switch gears and talk about high-dose CRT in acute liver failure. And this, as I'd mentioned to you, has become a game changer for us. And interestingly, I thought this would be almost getting to be standard of care in most large centers, but it's still a learning curve for some of the other centers as far as I think more and more hepatology groups and nephrology groups are now sort of buying into this strategy. So I think as a lot of you know, when you think about acute liver failure, so remember, we're not talking about chronic liver disease or cirrhosis. We're talking about acute hepatic dysfunction, so the Tylenol overdoses, for example. There is a clear correlation in this disease process between the degree of hyperammonemia and the risk of intracranial hypertension and herniation in ALF, in acute liver failure. So it makes it mechanistically attractive to decrease the ammonia in order to prevent herniation in these patients and bridge them to spontaneous recovery or bridge them to transplant. And this is where high-dose CRT comes in. When I use the term high-dose CRT, this is almost 3x what we do for general septic shock. So normally, just to sort of get into the weeds a little bit, normally in general septic shock, you are treating folks about 30 mils per kilogram per hour of dialysate dose. So that's about 2 liters of dialysate in a 70 kilogram patient. Here, you're cranking up the dialysate rates to almost 60 to 90 mils. So we start with about 4 liters. And the data suggests that when you spin them that fast on the dialysate, that's when you have a clinically significant decrease in ammonia levels and a timely decrease so that you can bring the ammonia levels typically less than 150, which is sort of our target, in order to prevent intracranial hypertension and herniation. And now there's more and more data coming out in the critical care world, in the hepatology world, documenting the benefit of high-dose CRT from a neurologic standpoint and also from a transplant-free survival standpoint. And so this has become our strategy. And you can argue that in a younger patients where you have sort of the brain that doesn't have much cerebral atrophy, you can even bring the ammonias down to 100 to prevent herniation. And so based on all of this, we have actually, I was involved in sort of creating these Society of Critical Care Medicine guidelines for liver failure. We've actually made a strong recommendation that in the setting of acute liver failure, hyperammonemia should be an independent indication for CRT, apart from all the other indications like hyperkalemia, metabolic acidosis. And this has become sort of the backbone of our strategy with respect to management. And so just to give you an example, we transplanted somebody with acute liver failure from hepatitis B about 6 months ago. And it just reminded me of how things have changed over the past few years. The patient had an INR of greater than 11. It was unmeasurable. So the liver was gone. The patient was pretty much anepatic. But the patient was texting on the phone as they were rolling into the OR. I'm not sure the texts were making sense, but at least they were texting. So just to give you an idea of the sort of the way we've been able to disconnect neurologic dysfunction from the coagulopathy. Because in the previous state, that patient would have herniated. But it's just been such a game changer that I just want to highlight this for you. So as you think about, hopefully there's not, you're not going to be interfacing with this, but if you have, for example, a Hep B reactivation or a drug-induced ALF that finds its way into this severe category, this is a very useful strategy that we will deploy in 5T South ICU in order to stabilize neurologic dysfunction, prevent herniation as you bridge them to spontaneous recovery or bridge them to liver transplant. So that's your CRT story. So let me just sort of switch gears again and finish up with plasma exchange. This is good old plasma exchange that is resurfaced in the management of acute liver failure. So the rationale here for using Plex is that when you have acute hepatic dysfunction, you have a cytokine storm that's coming out of the liver. And this has been studied in a few trials. And that cytokine surge then causes extrahepatic organ dysfunction. You have cerebral edema or the risk of cerebral edema, you have acute kidney injury, you have distributed shock. So there, it makes it attractive to think about using plasma exchange as a cytokine sink. You're basically blunting the cytokine storm, thereby mitigating multi-organ system failure. And so this is actually one of the few RCTs in our literature that shows a transplant-free survival benefit, published many years ago. Again, everything seems to be coming out of Europe. But this is data, again, that shows that when you look at an ALF cohort and look at high-volume plasma exchange versus standard of care, there was actually a transplant-free survival benefit. And in order to execute this, you need a really friendly blood bank. This is a lot of FFP. This is like 8 to 12 liters. I'll show you data that now we've scaled down to regular volume plex, and we're still holding on to the efficacy. And so about 2 to 3 sessions. And here's just some of the details of this particular study, looking at transplant-free survival as your primary endpoint. And you see a clinically and statistically significant difference when you compare the groups. The other thing I want to share with you that's interesting is that, and we've been doing this for a while as well now, it is remarkable to see the improvement in mean arterial pressure when you put somebody on plex with acute liver failure. And you have a dramatic improvement in mean arterial pressure, which sort of supports the theory that you're blunting the cytokine storm. And I think that in major part is how this system is working. You're improving systemic blood pressure, thereby improving systemic perfusion, and thereby preventing multi-organ failure. And then just for those of you interested, if you look at this study, they looked at sort of a subset of those patients, looked at the cytokine profiles, and they found a significant decrease in IL-6, TNF-alpha in the plex group compared to the standard of care group. And more recently, data out of India is actually scaled down to regular volume plex. So what we do for TTP or other indications is you're using 4 to 5 liters of FFP. And what this study showed is that when you scale down to standard volume plex, you still maintain the efficacy without and potentially decreasing and improving the safety as well. You decrease the risk of trolley, the personnel and the logistics required. So based on all of this, we have scaled down to regular volume plex. And I'll share with you sort of how we are coupling this with CRT. All right, let me just we're heading towards the end of this sort of talk, so I have time for questions. But I want to share this with you, co-administration of plex and CRT. And this is actually a case from many years ago. This is actually a Korean Airlines flight attendant who was passing through Atlanta on the way back to Seoul and was found down in a hotel room. I got a call from Grady. We think it was a herbal medicine, a weight loss supplement that caused acute liver failure. And she presented to Grady with basic and extremis, multi-organ failure. So neurologically, she had pneumonia of 500, grade 4 encephalopathy, got intubated on arrival. She was on every pressor possible, on max doses of norepinephrine, epi, vaso, angiotensin II, pH of 6.9, INR 7, transaminase of 10,000 range. So this, as you can tell, is not typically compatible with life. But she was 30 years old. So we said, let's sort of, as a Hail Mary, let's get her over here. And the first thing we did is we put a catheter in a IJ, started high-dose CRT based on the specs that I told you about, with a goal to fix the metabolic, fix the pH, fix the ammonia. So that was sort of step one. For the first time, we actually inserted a second catheter in the femoral site and co-initiated plasma exchange. We basically had 2 circuits going, and it's good to be 30 years old. She tolerated pulling blood from 2 circuits. With a goal to see if we make a dent in the shock and sort of mitigate the cytokine surge. And within 24 hours, we dropped her ammonia down to 150, and neurologic readouts were stable. We used pupillometry for sort of looking for ICPs. We corrected the metabolic acidosis. We brought it, and this is the first time I saw the efficacy of plex from a shock standpoint. We dropped the norepi down to just on single dose norepi, low dose norepi, within 24 hours. And then importantly, we bridged her to transplant. So we brought it into spec for transplant with respect to pH, pressure dose, and she sailed through transplant. And she's now 4 years out back in Seoul. So I share this with you because that in a previous world, this would not have made it. This phenotype of patient would not have survived. But I think it clearly, for me, illustrates how important, how significant high-dose CRT has been for us with respect to ammonia management and metabolic acidosis management, and then the complementary effects of adding on plasma exchange with respect to treating shock in these patients. So that is our general strategy for these patients. If Hopefully not. This is going to happen some frequency. But if you have a patient for some reason develops acute liver failure, the first order of business would be to administer high-dose CRT, and the second thing would be to add on Plex, as needed, depending on shock. All right, so just to summarize some of the points that I want to share with you, I think there is good evidence for the efficacy of MARS in the management of refractory hepatic encephalopathy in decompensated cirrhosis and acute on chronic liver failure. So that's become, as I said, a backbone of therapy. The role of albumin dialysis in cholestatic or sort of severe hyperbilirubinemia, and then bile acid nephropathy, so AKI associated with hyperbilirubinemia. I've spoken ad nauseum with you about the sort of the importance, I think, of high-dose CRT in the management of hyperammonemia in acute liver failure, the role of Plex in ALF. We actually have now, based on the positive study of sort of experience with Plex in ALF, we're now actually in a part of a multinational study looking at albumin plasma exchange in chronic liver disease called the Apache trial. So that's in the works, and I hope it's a positive study. I shared with you sort of the strategy of co-administration of Plex and CRT, sort of the synergy between those two sort of strategies. And then finally, future areas of investigation. I think from a Plex standpoint, there's always a debate. When do you start Plex? Do you preemptively strike with Plex, or you wait for shock? So that's something we're debating. How do you use optimal anticoagulation strategies, especially if these patients are coagulopathic? And then, as I'd mentioned, the holy grail is bioartificial liver support. If somebody is able to break that barrier, that would be really interesting. Thank you for your attention. I look forward to your comments and questions.
Very, very interesting. Thank you for that very comprehensive overview. I just have a question about the plasma exchange strategy. Has there been studies looking at exchanging with albumin instead of FFP?
Great.
To make a little bit more sense based on the market.
That's a great question. In fact, as we were thinking about starting this, I had the same question as to can we switch gears and use albumin instead of FFP? I have not seen any studies to that effect. Interestingly, the Apache trial that I'd mentioned, that is in acute on chronic liver failure, is actually using albumin instead of FFP for their clinical trial. As a sidebar note, the company that's sponsoring it makes albumin, so let's get that. But with that caveat, I think your point is well taken. Is there a role for using albumin instead of FFP for the Plex sessions? But great question.
Great talk. Not something that I was aware of, but we have a couple of general questions. Our content area.
So thanks for the question. So the conversations I've had so far that I've heard from some of your colleagues is that the unfortunate thing as I process these, I'm sitting in a hepatic world where I'm thinking about transplant. But the one major barrier as I process your calls is that we don't have that exit strategy or that bridge strategy to transplantation, unfortunately, given the oncologic history. So I have to sort of rethink that. So from a chronic liver disease standpoint, I pause as far as thinking about what we can do with these therapies. Again, on that spectrum, as I'm thinking about a question, if you can, when you think about chronic liver disease, you have a sort of spectrum. You can have early chronic liver disease where you can, also let's say some NASH or something that's not progressed to advanced portal hypertension. And there may be a role to use some of these devices as a bridge therapy to stabilization without transplant. But if you take somebody with advanced portal hypertension, then it becomes a bit tricky because what is the end game there with respect to stabilizing that? So going back to your question about, especially question of bilirubin level, that's a tough one. So, I'm used to thinking about bilirubins that are really high. So we're looking at the 30 range, right? So I've had occasional calls where, and I'll be curious to know, what sort of your cutoffs for preventing chemotherapy, for example. But the conversations so far I've had are sort of more, much lower bilirubins of the sort of the 5 range. And there, I'm not sure, we can always try it, but that's not been our standard of care as far as what kind of bilirubin levels. So going back to yours, so maybe your context, what would be a typical bilirubin level that will prevent starting chemotherapy?
Or therapy, but not that convincing. So can we keep this sort of two events, we get them over the hump and hopefully the recovery.
Yeah. Yeah, so VODs, as you know, is tricky, right? So that is sort of a different process where you basically have outflow obstruction. And so there it may be, you're not fixing the underlying problem. The cases where I shared with you for severe cholestasis is just acute intrahepatic cholestasis, where the plumbing is fine, the inflow and the outflow is fine. So you have a very transient, or not, hopefully transient parenchymal injury, and then you can almost cleanse and decrease serum bilirubins and then wait for the liver to kick in. Yeah? The VOD is unfortunately less of a reversible process. So that will give me some pause. But I look forward to further conversations. I think we're sort of a bit of a learning curve with respect to seeing how we can think together about some of these patients, especially now we have these tools. Yeah.
I have one other case. Well,
Definitely. So I think there, I don't know about the syndrome, but that would be a clear, I think in my mind, to start high-dose CRT and stabilize their neurologic function and control the hyperammonemia as you continue to treat them. So I think that would be a perfect example or perfect situation to use high-dose CRT.
You comment on preclinical or clinical studies evaluating liver stem cells to facilitate liver regeneration, particularly stem cells derived from IPS.
So slightly outside my wheelhouse, in full disclosure, I'm actually in the process of collaborating with a sort of a European company that's looking at, I guess I'm not able to give you all the details for sake of sort of can't disclose it, but there is a mesenchymal stem cell that is being studied. It's a pluripotent stem cell that is being, we think is differentiating into the hepatic sort of characteristics that we can use. But that's my only exposure to that field. So I'll have to get back to that question with more details, with more of a detailed response. Yeah.
From Mars, you mentioned the little molecules and provide some of many that impact it. And I'm thinking of physiological consequences, that were consequences that can happen. So nitric oxide, and you mentioned that hemodynamics could improve. On the other hand, they would be taking the coronary disease that are dependent on nitric oxide. Do you see that as an issue when you deal with Mars?
So that's a great question. Thanks for that. So this sort of speaks to the unintended consequences of extracting the good molecules, if you will. So I don't know about sort of CAD in particular, but your question raises the issue. There's published data now that are you removing in the ICU setting, are you affecting sedatives, the bioavailability and the pharmacology of sedatives, antibiotics? So meropenem is highly protein bound, vancomycin is highly protein bound. How are you affecting the pharmacology of those drugs and the pharmacokinetics of those drugs as you use Mars. So we are still on a learning curve. We tried to have some rough guesstimates with our pharmacists about how to readjust the dose. But that's a great question. As far as I think we're learning about how we need to compensate to prevent the negative effects of Mars on therapeutic molecules. So that'll be a response to that question.
The question, this is the discussion of immune-related anxieties, especially in oncology. And so in GI oncology, for example, those classes of medications are the mainstay of the frontline therapy. And for patients with a concern carcinoma with background of baseline function, sometimes you see additional, disease that can be often advantage with some level of pressure on steroid treatment. I'm just curious if you have any experience with patients who have very bad active and using
Thanks for that question. So I think luckily, these patients are, I would say, as I think about it, less acute in the spectrum. So I'm thinking about the outpatient setting of autoimmune hepatitis, for example. That would be the setting of the clinical correlate to this. So luckily, I think those patients are not progressing, the last I checked, to, at least I haven't seen anybody show up in our ICU with respect to acute liver failure. So they are developing hepatitis, which may find their way into sort of the outpatient setting or the non-ICU inpatient setting, but not requiring or having that disease severity that requires more aggressive support like we spoke about today. So hopefully we can not see them in the ICU setting.
Might there be a role for this in immune-mediated hepatotoxicity induced by immunotherapy? I don't believe the agents causing the toxicity are known. Perhaps the technology would remove them.
So that's a great question. I think it's another area of investigation as I sort of responded to the previous question. I think as you look at the spectrum or the severity of disease, hopefully this will stay outside the ICU that would not necessitate some of these aggressive extracorporeal therapies.
Thank you very much, Dr. Subramanian, for that excellent talk. And we've taken a good number of questions from the Q&A feature. Just to remind everyone that next week we have Dr. Jane Micel from Emory University presenting on optimizing treatment for early stage triple-negative breast cancer. And to view all upcoming Winship Ground Round lectures, please visit the Ground Rounds page on the Winship Cancer Center website or the Winship calendar. Thank you all so much for coming this morning, including those who attended virtually. I will see you all next week. Thank you.